Hello, everyone. Welcome to another session on eye health. Today, we speak on diabetic macular edema, chronic condition that affects persons with diabetes. And we will be talking to Dr. Padmaja Kumari Rani, who is Network Head, Tele-Ophthalmology and Vitreoretinal Surgeon at V Prasad Eye Institute. Um, we will focus on treatment and prevention of diabetic macular edema, and this is really relevant for persons with diabetes today. And I'm Aparna Mittal. I'm the founder of PatientsEngage. For those of you who are not aware, PatientsEngage is an online platform where we seek to inform, engage, empower patients with chronic diseases and their family caregivers. We do believe that patients with chronic diseases need to be better informed about their condition, and the better informed they are, the better choices they will make in the management of their chronic diseases. So if you've not checked out our content, do check out and follow us so that you don't miss out on our content. Um, this series is part of a collaboration with iHope. iHope is the Indian Health Outcomes Public Health Economics Research Center, and it's an exciting and collaborative interdisciplinary interdisciplinary research center that has been set up with a research grant from Wellcome Trust DBT India Alliance through collaborations with LV Prasad Eye Institute, Indian Institute of Management Ahmedabad, and Indian Institute of Public Health Hyderabad. The focus of this center is big data analysis, health economics, clinical and public health research, and eye health. And please do visit ihope2020.org for more information. Our guest tonight is Dr. Padmaja Kumari Rani, Network Head, Tele-Ophthalmology and Vitreoretinal Surgeon, Consultant Ophthalmologist, LV Prasad Eye Institute. She's currently the Adjunct Associate Professor of Ophthalmology at the University of Rochester, New York. She did a postdoctoral fellowship in vitreoretinal diseases. She's a fellow of National Board at Shankara Nethralaya, Chennai, followed by a fellowship and an FRCS. She's published in many journals and is an expert in the management of diabetic retinopathy. She's passionate about building and mentoring screening programs for retinopathy of prematurity. A reminder to our viewers that information here is to inform you, but does not replace a medical consultation. Please do consult either your doctor for specific medical issues or the doctor we are speaking with. If you have a question, you can ask in our forums on patientsengage.com. You have an experience to share, you can write into us at editor@patientsengage.com. And follow us on our social media pages. We are on Twitter, LinkedIn, YouTube, Facebook, and Instagram. And as I said, the website is www.patientsengage.com. So without much delay, let's get started by talking to Dr. Padmaja Kumari Rani. Welcome to this discussion, Dr. Padmaja Kumari Rani. Thank you for taking the time to speak with us and to inform our viewers about diabetic macular edema. Today we are going to talk about diabetic macular edema. So can you tell us what is diabetic macular edema?
So diabetes is the most common public health problem that we face today. And if we look at overall people in the world, almost 531 million people are having diabetes as on today. And 50% of them are living in India, USA, and China. So that way we are very developed with having a number of people. And when we look at diabetic macular edema in particular, so eye is like a camera. So I would just like to share with you a few small video to show how actually diabetes macular edema occurs. Okay. So if you see we say in our pronouns that, Sarvendriyanam Nayanam Pradhanam. So eye is like a camera and retina is like a film. And we see that the back part of the eye, which is we call retina, and the center part of the retina, which we call as a macula.
Right.
This macula is mainly responsible for the reading and writing vision. So this is a very sensitive, visually sensitive part in the center of the macula. So when normally in the camera, how the film is very important to create image. So in the retina also, when you have this center, this retina is a very transparent membrane.
Right.
So when a transparent membrane is there, you expect that when the image comes and then light rays fall into the eye, you expect a clear image.
Right.
So whenever due to diabetes, what can happen is that this instead of this transparent membrane, you can have, because of the blood sugar and gets accumulated everything. So this transparency of the membrane gets disturbed, and that becomes, there will be deposits in the form of proteins and small spots and dots, and this transparent membrane will become all like yellow dots and red dots instead of a clean membrane.
Right.
And that's how the patient will come with a blurred vision. And so when there is a thickening or edema or thickness of this central part macula, that is what we call as a macular edema. So I'll show you beautifully in one video. So any diabetic patient when we come, or even a patients who are above 40, any people, they should have something called dilated eye examination. What is meant by dilated eye examination is, when we put drops, there is something called pupil and lens, and when we put drops, this will become dilated.
Right.
And able to see the back part of the eye. So you can see that this is again a normal retina. You have a normal optic disc, and this is the center part of the macula, which doesn't have any yellow dots or red dots.
Right.
This is normal retina. Whereas if you see a patient with a diabetic patient, if the same patient, if we put drops and we dilate and see either by fundus camera photograph or by examination, what we see is that you will have the central part, that is the macula, is having so many yellow dots. You can see very clearly so many yellow dots and red dots, and which is causing thickening, and what causes the impaired vision. This is what in nutshell I could say. Switch it off this, and then
or maybe we can, yeah, okay, switch it off for now.
Yeah.
So, what are from a layperson's perspective, what are the symptoms of DME? And for the audience, when we say DME, we mean diabetic macular edema. So what are the symptoms that they should watch out for? Are there any symptoms at all?
So diabetic macular edema, what we call as a sight-threatening or vision-threatening type of diabetic retinopathy. So diabetic macular edema is again actually mainly occurs in the patients with diabetes, and it is also part of diabetic retinopathy. So as I said, eye is like camera, retina is a film. So when the retina small micro vessels, when they're affected, we call diabetic retinopathy. And when it affects the central part of the macula, we call diabetic macular edema. So in diabetic retinopathy per se, there will not be any symptoms or signs. That's how patients land up in sight-threatening complications. But when DME, the sight-threatening complication of diabetic retinopathy, so patient typically will have something like a blurred vision. And most commonly, patients, what they do is they go for an optical shop or some glass checkup, and they think that it is probably because it typically occurs in 40 to 50 years of age group. So they think that they may just require to change the glasses. So they will go to an optical shop, glass power, and they think that, okay, maybe glasses can be corrected. But that is when they will realize that this DME, whatever the blurred vision that they occur, will not have symptoms due to, they cannot be corrected by glasses. So, and this can be detected only by the way I showed, dilated eye examination. And when we check the fundus, the retina, then only we will detect the diabetic macular edema.
Right.
So
Okay.
they will have blurred vision. Yeah.
So blurring of vision is the most common symptom.
Yes.
Okay. And then I think you said that, it's related to diabetic retinopathy. So is it treated as a, do you, from a layperson's perspective again, is it a subtype of diabetic retinopathy or is it a complication of diabetic retinopathy? What would you consider or how would you describe it to a patient?
So, as I said, it is a type of diabetic retinopathy. So, whenever we have a patients with diabetic retinopathy, as I said, the retina normally a transparent membrane. So, when
Right.
early stages, what we see is when mild diabetic retinopathy, you may just see small red dots, like that in that membrane. But when there is a diabetic macular edema, that is a thickening because the glucose accumulates and the retina remains, so the thickening starts. Then you start having this diabetic macular edema in the form of these yellow dots and red dots and causing thickening. And that is when the patients start having visual problems. So in a diabetic retinopathy, patients typically, initially, they may not have any signs and symptoms. And once DME comes, then they'll have blurring vision. And when you see around, for example, 100 patients with diabetes, you can expect diabetic retinopathy to occur in around 20 people, that is around 20%.
Right.
But among diabetic retinopathy patients, the diabetic macular edema can be seen around 10%.
Okay.
So it is actually the most common form of diabetic retinopathy and also sight threatening.
Right. Okay. And, obviously diabetes is the biggest risk factor for diabetic macular edema, but is there any other, are there any other risk factors or it's only diabetes? And
So
what increases the risk?
yeah. So we need to consider the diabetes is a systemic disease, and the important risk factors for diabetic retinopathy also hold good for the diabetic macular edema. So what we see is that the diabetic macular edema is depending on the type of diabetes. So there is something called type 2 diabetes, which we see more in older individuals,
Correct.
and type 1 diabetes, which we see in younger individuals and
Yeah.
who are also dependent. So what we see typically, diabetic macular edema, DME, is more common in type 2 diabetes.
Type 2 diabetes. Okay.
With type 2 diabetes, who are older individuals, who are obese, who have obesity is another risk factor, and also who have, as I said, a lot of yellow dots accumulate, right? So there's a lot of any lipid metabolism like dyslipidemia, lipid abnormalities, lipid profile abnormalities, and also hypertension. Hypertension is a very significant risk factor. And then the another most important risk factor is also the patients with kidney complications due to diabetes. We say diabetic nephropathy.
Right.
So both retinopathy and nephropathy, they actually go hand in hand. So luckily the retina is one important structure where we see blood vessels directly. So the DME is also very common in patients with kidney disease due to diabetes. So these
So
are the
essentially,
risk
if you're
factors that
someone
we.
with diabetes who has multiple complications, you're likely to also have, because, as you said, that the nephropathy is because of complication of diabetes. Cardiovascular conditions can also be due to complications of, and they can be independent risk factors as well, but often they are linked to diabetes. And then you're saying for those patients, the risk of retinopathy and macular edema is also high. And you mentioned dyslipidemia as well.
Yes.
Okay. If you can also tell us if there are different types of diabetic macular edema.
So when we look at, again, probably I can just share one slide to show. So when we look at diabetic retinopathy, diabetic macular edema, so when these yellow dots are red dots, which are just this is, as I said, this is the center of the macula, which we call fovea, which is actually responsible for our reading and writing and near good vision. So when these retina is transparent in the center, but there are few yellow dots or something away from the center, we call it as a mild diabetic macular edema.
Okay.
And when we have these yellow dots and red dots, which you can see very clearly here, they're approaching the center. That means that this is when actually patient starts experiencing the blurred vision. This we call it as a moderate diabetic macular edema. And you can see very clearly the severe diabetic macular edema in this third picture, where you can see that the whole center is accumulated with a lot of yellow spots or hard exudate, we say, and then the patient will have a severe vision loss. So when we look at this is how we actually classify or categorize diabetic macular edemas.
Okay, thank you. So we've talked of what is diabetic macular edema. We've talked of the symptoms. We've talked of the risk factors. We've talked of types. Is there any treatment for diabetic macular edema?
So again, the most important thing we need to understand is, again, in diabetic macular edema, the important treatment in diabetic macular edema is, again, the first important cornerstone of treatment is good diabetes control. So when I said that mild, moderate, and severe, right? Mild DME, diabetic macular edema, the main important treatment is only in the systemic control, in terms of good diabetes control, good hypertension. Then also when we say diabetes control, we aim at HbA1c levels around 7. And then when we look at blood pressure control, when we look at it around below 130 by 85. Then also, having salt restriction in terms of at less than 5 grams per day. Then dyslipidemia, that is the lipid abnormality control. And then lifestyle changes in the form of physical exercise in terms of at least 30 minutes walk per day, and dietary changes, because all this will hand in hand go more into control the diabetes as well as the mild diabetic macular edema. And when we look at moderate diabetic macular edema and severe diabetic macular edema, the important cornerstone of treatment is in the form of injections that we give inside the eye. We call as intravitreal injections. And we actually, all these injections play in two types. One we call, there is a factor which is responsible biochemically, responsible for this macular edema or causing this, changing the transparency of the retina, is a factor called VEGF. We say vascular endothelial growth factor, which is released by those blood vessels. They causes the leaky and causes the swelling. So all our agents are based on these inhibiting this factor. So we call it as an anti-VEGF injection.
Right.
And there is also a theory of inflammation playing a role in diabetic macular edema. So we also propose giving in the form of injections called steroids. So if I say in terms of three things: systemic control, anti-VEGF injections, and steroids. So these are the main therapy arms that we choose. Systemic control is constant for any type of diabetic macular edema. But in terms of anti-VEGF injections are the main initial therapy that we start giving these patients. And then the steroid injection, sometimes if they don't respond to anti-VEGF, we give the steroid injection.
Okay, thank you. And so the question obviously would be, can DME be prevented? And I would also want to add, I think you've kind of addressed, but if you want to reiterate the point of, can the progression of DME be prevented as well, right? So two parts to it. Can DME itself be prevented, and can the progression of DME be prevented?
So typically how I explain to my patients in a clinic, in a day-to-day clinic, when we see that. So what I say that your eye is like camera, retina is like film, and you are having blood vessel supply has been reduced because of the lack of oxygen due to your glucose accumulation, and you are having a DME. So, and I'm going to give some injections which will act like a physiotherapy. That means we do also an investigation called OCT, which is a non-invasive. It is just like a histological biopsy, and it will tell you DME how much is there. So we can quantitatively know how much edema is there and all that. And also, of course, vision acuity. So what I say is that typically when we do that, it is actually injections are acting like a physiotherapy. So they reduce the swelling. So you're likely to get some improvement in the vision. But the root cause is the diabetes. So if the diabetes is not under control, for example, if a patient with a kidney problem, and if the kidneys are not functioning properly, the kidneys' main function is to filter all the proteins and, to make sure that the toxins are not accumulated in the body. So if a diabetes patient and along with kidney disease and having a DME, if the kidney problem is not controlled, even how much ever I pour in the injections, it is not going to help. So it's very important that we need to control the systemic factors. Along with the injections will help like a physiotherapy. So the root cause for the stroke is diabetes. So when that is under control, along with the injections, it will help in terms of preventing the progression of DME, even prevent the DME also.
Right. So if I am someone who's just been diagnosed with diabetes, how often should I, get screened for DME? And, is that the same? So when I go for a diabetic retinopathy screening, is that the same time they'll also do a DME screening, or is that differently done?
No, I think very important question. So when you are diagnosed with diabetes, what we have found typically is that even when you are newly diagnosed as a diabetes, so diabetic retinopathy is supposed to be a duration dependent. That means, for example, you have been detected as a diabetes today and you will not develop diabetic retinopathy next day. It is supposed to take around 5 to 10 years. But unfortunately, due to lack of systematic screening programs and all, many people, even with newly diagnosed diabetes, we found that about quarter of them, around 25% of them already have a sight-threatening diabetic retinopathy. First of all, they never even knew that they had
diabetes.
And then they already had the complication of diabetes, that is diabetic retinopathy. So what I would recommend is that, for example, if it is the patients who are having type 1 diabetes, that is the younger individuals, they should, because they are detected around 10 years or 12 years that they are having diabetes, within 5 years, they should go for diabetic retinopathy screening. When I say diabetic retinopathy screening, it is mainly by dilated eye examination or by fundus photography. That is must. So when we do diabetic retinopathy screening, we will also know whether DME is there or not. Because as I showed in the photograph, the central part is the macula. So you will know whether DME is there or not. But if you are having a type 2 diabetes, many a times in India or whatever, our common way of diagnosing diabetes is when they go for some opportunistically, when they go for some cataract surgery or some accident or something, that is when they actually know that they have diabetes. So if you have a family history of diabetes, or if you are above 40, and if you have any risk factors like hypertension, dyslipidemia, or if you are already going for some surgery and all, when you're doing, it is always good to have one eye examination, dilated eye examination above 40. Should be a part of the comprehensive eye checkup. Along with how we say, when we say comprehensive eye checkup, we should also have something called a eye pressure, that is IOP, and then dilated eye examination. Because diabetes patients not only can have diabetic retinopathy, but also can have sometimes the increased pressure like glaucoma. So it's important to have a comprehensive eye checkup and dilated eye examination to detect diabetic macular edema.
So the question on that, so you said, okay, it's also for people with type 1 diabetes, but they can start, say, 5 years after their diagnosis, but people with type 2 should start immediately. In terms of, one of the conversations we had when we did the discussion on diabetic retinopathy was that if you manage your diabetes early, so the first 5 years of your diabetes, if you manage it well, your risk for diabetic retinopathy is,
Yes.
is reduced. Is
Yes.
that the same for diabetic macular edema as well?
Yeah, absolutely. So what you describing it is what we known as legacy effect or metabolic memory we call. And that is a very important concept for both diabetic retinopathy and DME. And it's very important that that's why type 2 people, diabetes, when they start immediately, they'll have a dilated examination and detecting at the level of diabetic retinopathy. And they start also good control of diabetes. We can expect that they don't have a complications later on. And another third population that one should be aware is, like, for example, there are two categories, like women who are pregnant can develop diabetes during gestation.
Correct.
And also hypertension. And they may not develop DME during the pregnancy. That is, we call as gestational diabetes.
Right.
They also should have at least one baseline examination, because we find that many of these women go on to become diabetic.
Correct.
Later
Their
on.
risk of diabetes increases.
Yeah. It's something like a type 2 diabetes, which is occurring in later age. So it's good to have one baseline examination. There is another category of women who are diabetic and who become pregnant. Right? So they have an increased risk for diabetic macular edema, because pregnancy itself can increase the risk of diabetic retinopathy and DME. Because pregnancy, as we all appreciate that, a lot of swellings happen, the legs will swollen, even the eye front part, cornea also sometimes can be swollen. So the fluid accumulation happens. So similarly, diabetic macular edema also can increase during during pregnancy. So it's very important that the diabetic women who want to become pregnant should have at first trimester, they should have one dilated examination to know the level of retinopathy, and then every trimester they should have one more examination, second and third, so that, because the pregnancy itself can progress the diabetic.
Right. I think that's a very important thing, because people don't think of those kind of scenarios where they're more concerned about managing their pregnancy because of their diabetes, but don't think of other complications. You mentioned that if you have gestational diabetes, then you should do baseline eye checkup. When should that baseline eye checkup be done? This is for those who had gestational diabetes. They were not diabetic before. They had gestational diabetes.
That is recommended that at least after delivery, within 3 months, it is good to have one baseline examination, because it is very easy to forget that, because as soon as the pregnancy done, they will even forget that they developed diabetes, they developed hypertension. But it's good to follow it up with again a diabetes checkup, whether they turned into pre-diabetic or diabetic. That can be checked by glycosylated hemoglobin or oral glucose tolerance. It's good to follow up that, and along with one eye checkup. What is the advantage of having eye checkup is, as I said initially itself, eye is like a window to the blood circulation, because this is the only part of the body where you can see blood vessel health directly. So the simple fundus photograph can tell us that whether not only the patient is having diabetic retinopathy, but also is having any hypertension effects, or could be, when you have the diabetic retinopathy, you can expect that the similar complications of diabetes occurring in the kidney as well. So it actually gives you overall, it's like a window to the body health. So it's important to have that.
Thank you. Thank you so much, Dr. Padmaja, for taking the time to explain to our audience about diabetic macular edema. And I think we've covered a lot of important points about the condition itself, but also how to proactively prevent it and to prevent the progression of it. So thank you very much.
Thank you.